So I'm going to focus on two newly developed programs from our research group regarding treatment-resistant schizophrenia and treatment-resistant bipolar disorder, both published by Springer Nature. So treatment resistance is determined by the following factors. The correct diagnosis was made, the treatment was proposed, but the treatment response is inadequate. Treatment resistance can be primary or secondary. The switch to clozapine or a combination of clozapine and other antipsychotic agents presents the best solution for treatment-resistant schizophrenia regarding pharmacotherapy. Over 30% of individuals with schizophrenia belong to this category. They have huge cognitive dysfunctions, especially in verbal memory and language, high rates of suicidality, many comorbidities related to physical and mental health, and high rates of social isolation. Our recovery treatment-resistant GR consists of 190 sessions. We administer tests before the treatment. Then we begin with an introductory phase of 20 sessions. We try to make a restart with pharmacotherapy. We try to make therapeutic relationship and alliance. We offer psychoeducation to patient and family. Then we go to the second phase, which consists of 160 sessions. We begin with two individual therapies, cognitive behavioral psychotherapy for psychosis and cognitive-oriented therapy, according to Beck and colleagues. And we make a pause of 2 months, and then we go to the group psychotherapeutic phase, in which two very famous and efficacious rehabilitation programs are offered. The integrated psychological therapy for 50 sessions twice a week, and the metacognitive training. So our recovery treatment-resistant GR consists of 190 sessions. And as I said before, the second phase has a cognitive phase in which cognitive behavioral psychotherapy for psychosis and cognitive-oriented therapy according to Beck are implemented. Then we go to a pause of 2 months, and then we implement group psychotherapeutic programs such as the integrated psychological therapy for 50 sessions twice a week and metacognitive training for schizophrenia twice a week, 10 sessions twice a week. Then we go to an epilogue, which is consisted of 8 sessions. Relapse prevention and recovery as a process are the main issues. And finally, we offer 2 monthly individual sessions. We administer tests after the therapy and 6 months after the therapy, and we give the possibility of repeating the therapy in case of relapse. Our program is now evaluated in this clinical trial and is compared with treatment as usual with a control group. But we have implemented a pilot group, and this is a feedback of one of our patients and a very good example of a recovery process. A patient says, I want to die by suicide. I have gone to numerous mental health experts. I slept all day, and the rest of the day I smoked and consumed a lot of junk food. I was very desperate with my life. I attempted to find a job. I decided to start with this therapy. I have learned what the issues of TRS are, why I took so numerous medications, why clozapine helped me, and how psychotherapy could help me. Psychotherapy helped me manage anxiety, depression, lack of motivation, coping with delusions and hallucinations. I have moved forward my relationship with my family. So, and here is a clinical trial which we have conducted between 2022 and 2024. regarding the evaluation of the group psychotherapeutic phase of our recovery treatment-resistant CR. So we evaluated the combination of pharmacotherapy, IPT, and metacognitive training. And we have some statistical significant results regarding cognition, psychopathology, functional outcome, and recovery. We have also conducted a regression analysis for the whole sample of 35 people, and some of the results are, for example, 54% of the problem solving, of the improvement of problem solving, 45% of the improvement of negative symptoms, and 22% of the improvement of recovery can be explained through this combination of treatments. And when we focus on the 32 people, 54% of the improvement of verbal memory, 41% of the improvement of negative symptoms, and 25% of the improvement of recovery can be explained through the improvement through these treatments. We have a total therapy effect size, a medium effect size of 0.72, medium effect sizes for psychopathology, recovery, and cognition, and large effect size for functional outcome. And when we focus on the 32 people with treatment-resistant schizophrenia, we have a medium effect size of 0.41 and medium effect size for psychopathology, recovery, functional outcome, and a small effect size for cognition. This is the manual for treatment-resistant bipolar disorder. It is characterized from the fact that the classical medication or the classical agents are not effective, and psychiatrists should find the right combination of medications. And the problem is that treatment resistance arises in 20 to 60% of patients with mental health disorders. Our program consists of 140 sessions. We administer tests before the treatment, then we make an introductory phase, then we go to the second phase, which lasts about 108 sessions. The first phase, the cognitive phase, in which cognitive behavioral psychotherapy for bipolar disorder and cognitive-oriented therapy are implemented. Then we go to a pause of 2 months, and then we offer group psychotherapy, and especially metacognitive training for bipolar disorder for 8 sessions once a week. Then we go to an epilogue with 8 sessions. And finally, we offer 4 monthly individual sessions as follow-up. We administer a test after the therapy, 6 months after the therapy. We give the possibility of repeating the therapy in case of relapse, and we recommend cognitive behavioral psychotherapy, couple therapy for people who participated in our program. So this is a feedback of one of the patients who participated in our pilot group, a very good example of recovery in process. This patient highlighted the fact that he understood what treatment-resistant bipolar disorder is, why CBT and metacognitive training had helped him manage depression, mania, hallucinations, and he also learned to communicate better with the family. This program is nowadays under evaluation in this clinical trial and is going to be compared with a control group. Our programs have advantages and disadvantages. The disadvantages are that they are long-term treatments and that intensive grief reactions can be activated. This can be an advantage in the long term. The advantages are that they offer psychoeducation, evidence-based pharmacotherapy, evidence-based psychotherapy and rehabilitation. We avoid polypharmacy. There are long-term treatments which are necessary for treatment-resistant schizophrenia and bipolar disorder, and they lead to recovery and resilience. So thank you very much. Our programs are dedicated to all people who suffer from treatment-resistant schizophrenia and bipolar disorder.